Greetings, my name is Marina Plesons. I work with the Department of Sexual and Reproductive Health and Research at the World Health Organization, and I'm pleased to speak with you today about responding to the sexual and reproductive health needs of adolescents in the context of the COVID-19 crisis. COVID-19 has had a tremendous impact on the lives of adolescents and on their sexual and reproductive health. As we heard in Module 3 from colleagues from Population Council, from Guttmacher, from GAGE, and from WHO, COVID-19 has caused stress and uncertainty among adolescents and their families and communities. It's interfered with their friendships and their relationships. It's disrupted education and also health services. It's created economic hardship and food insecurity, especially in the early days of the pandemic. It's increased domestic work and care obligations for many adolescents, and increased violence in some cases. And importantly, across all these domains, it's exacerbated inequalities. As such, adolescents have many immediate and pressing needs in this context, and one of those relates to their sexual and reproductive health. And as Shirin Jejeboy said, we cannot let the huge advances we have made thus far in accelerating girls' and boys' education, delaying child marriage, addressing sexual and reproductive health needs, and building agency, as we heard about in Modules 1 and 2 of this e-course, be dissipated. Soon after COVID-19 reached the global stage, WHO issued 2 guidance documents on maintaining essential healthcare in the context of the COVID-19 pandemic, and these 2 guidance documents address all population segments and all health issues. The first of these 2 guidance documents is on the left side of the screen, and it's titled Maintaining Essential Health Services Operational Guidance for the COVID-19 Crisis. It sets out practical actions that countries can take at national, regional, and local levels to reorganize and safely maintain access to high-quality essential health services in the pandemic context. It includes sample indicators for monitoring essential health services, as well as considerations on when to stop and restart services as COVID-19 transmission recedes and surges. The second guidance document is on the right side of the screen, and it's titled Community-Based Healthcare, Including Outreach and Campaigns in the Context of the COVID-19 Pandemic. It sets out practical recommendations for decision makers to help keep communities and health workers safe, to sustain essential services at the community level, and to ensure an effective response to COVID-19. Again, these 2 documents include introductory sections on cross-cutting issues across all population segments and health issues, and then they include sections specific to different population segments or stages of the life course and specific health issues. Given that the 2 guidance documents on the previous slide cover all population segments and all health issues, it wasn't possible to include a great detail of information on the specific measures to take related to adolescent sexual and reproductive health and rights. As such, WHO worked with UNFPA to publish an additional technical brief titled Not on Pause, Responding to the Sexual and Reproductive Health Needs of Adolescents in the Context of the COVID-19 Crisis. This technical brief on the bottom right of your screen is part of a 3-part series that covers my body, my life, my world, including question and answers and information about a campaign with adolescents and young people. The Not on Pause technical brief includes a brief introduction, sets out some key considerations in responding to the adolescents' sexual and reproductive health and rights in the context of COVID-19. And then the bulk of the document is about recommendations for delivering the Guttmacher-Lancet Commission's essential package of SRHR services and interventions to adolescents in the context of COVID-19. Specifically, for each of the 8 areas you can see here in the blue boxes, it sets out recommended actions, specific measures for delivery of services, monitoring and reinstatement triggers, and considerations for transition towards restoration and recovery, or the new normal. Since publishing the technical brief, WHO and UNFPA have been working to identify promising initiatives in responding to the sexual and reproductive health needs of adolescents in the context of the COVID-19 pandemic. So in essence, organizations or governments that have applied some of the recommendations included in the technical brief so that people can see how these recommendations can turn into more than just words on a page and provide inspiration for others looking to work in this area. Specifically, we've asked initiatives 5 questions. What were you delivering this service to young people before the COVID-19 crisis? What new approaches are you using to overcome the barriers created by COVID-19 and the response to it to reach young people with this service? Why did you decide to use these approaches? How did you develop these approaches? And what are you doing to find out if these steps are in fact working? The next step that WHO and UNFPA are going to be doing is we're going to be working with a youth-led organization to do an independent vetting process of the service providers included in these promising initiatives by organizations led by adolescents and young people themselves. The first intervention featured in this technical brief is provision of comprehensive sexuality education, or CSE. The recommended action in general terms is to modify this intervention in the context of COVID-19, and specific measures for delivery of the service include to communicate CSE messages through mass media or digital media to which adolescents have access, to inform healthcare providers on the important role they could play in informing and educating adolescents, and ensure that they have access to age-appropriate, accurate, and up-to-date information that they can pass on to adolescents, to explore possibilities of delivering CSE out of school, following local policies on physical distancing, and ensuring access to personal protective equipment during trainings, and to provide educators, including peers, with updated information on COVID-19 and how it affects young people. And lastly, to encourage healthcare providers to use contact with adolescents to communicate key CSE messages, to provide educational materials, and to inform them about educational programs in mass media or digital media where available. Now, the example that we're going to share here of a promising intervention addresses the first of these measures. This promising initiative comes from an organization called Education as a Vaccine in Nigeria. Education as a Vaccine already had a diverse portfolio of digital initiatives before COVID-19 pandemic emerged. These included an SMS-based platform online for young people to ask questions and get answers from trained counselors on their sexual and reproductive health and relationship concerns for free by texting questions to a short code. It also included mobile applications, including something called Frisky, a sexual health information and risk assessment app, and Diva, a menstrual health and care app for girls and young women. And then they also shared information and had conversations with adolescents and young people about sexual and reproductive health on social media, including on Instagram, Twitter, and Facebook. Once COVID-19 pandemic emerged, they complemented these activities with a few additions. Firstly, radio jingles and WhatsApp campaigns to provide the right information and debunk myths and misconceptions. And they also retrained counselors to provide information on counseling without discrimination. To determine if these additions are working, they're using inbuilt analytics in these digital platforms, and they're seeking direct feedback from young people. The second intervention in the technical brief is provision of contraceptive counseling and services. The recommended action in general terms is to maintain and modify this intervention, and specific measures for delivery of the service include to inform adolescents where and how to access contraceptive counseling and services, including changes, if any, to service delivery times, locations, etc., during the COVID-19 response. 2, in health facilities, to ensure that adolescents have access to the full range of contraceptive methods, including condoms and emergency contraception. 3, to ensure that forecasting for commodities and procurement planning are taking into account adolescents' needs and adjusting for potential alterations in method choice. Next, in case the preferred method is not available, to support the adolescent to identify an alternative method that meets his or her needs and preferences. To consider waiving restrictions if these exist, such as those based on age, marital status, or parental or spousal consent, and providing services free of charge. To consider providing multi-month supplies with clear information about the method and how to access referral care for adverse reactions. That counseling and services should continue to be provided discreetly and confidentially to adolescents, especially if someone else accompanies the adolescent to the consultation. to consider establishing alternative delivery modalities for contraceptives that are more accessible to adolescents, such as through pharmacies, shops, or community-based delivery. And then finally, to consider setting up hotlines for adolescents to provide information and advice on contraceptive self-use, side effects, and method choice, or other sexual and reproductive health related questions. The examples that we'll share primarily relate to the first and last of these recommendations. The first example that we'd like to share with you is from an organization called Love Matters in India. In Bihar, a state in India, Love Matters launched a WhatsApp chat box service called Ranjana to answer adolescents' questions related to sexual and reproductive health, including contraception, to direct adolescents to the nearest clinic that's providing adolescent-friendly services, even in the context of COVID-19, and to connect adolescents with the nearest peer educator that's already been trained to support adolescents in order to facilitate home delivery of certain contraceptive methods if they're needed. Love Matters is doing a few things to understand if these modifications or additions are working. Specifically, they're conducting focus group discussions with adolescents, and this in the first place revealed a need for such a service. And they tested this idea using a proof of concept pilot. The second example for this intervention comes from Kaiser Permanente in Washington State, United States of America. In response to COVID-19, Kaiser Permanente instituted telecounseling services to promote and facilitate easy access to services. Depending on the case, this is followed up with video counseling. For example, if they need to present different contraceptive options. If home management is not possible, for example, through a home pregnancy test or pharmacy purchase of contraception, a clinic hospital appointment is set up. And an example of when this might be necessary is if there needs to be an insertion of an IUD. And then virtual or physician contact is used to check on other issues, for example, HPV vaccination status or advice on HIV or STI risk reduction. To determine if these modifications or additions are working, Kaiser Permanente is instituting follow-up calls with adolescents or young people that use the services, and they seek online feedback on their satisfaction. The third example of a promising initiative on contraceptive is from Pathfinder International and the Ministry of Health in Ethiopia. Pathfinder International had supported the Ministry of Health's efforts to improve access to and adolescent friendliness of public health facilities in 4 regions of the country since 2007. When COVID-19 crisis emerged, Pathfinder supported the Ministry of Health to do a few additional things. They set up Telegram groups in each region with regional and district WREDA staff, health facility managers, health service providers, and peer educators to provide accurate and up-to-date information. Telegram is a communication app that's readily available on most mobile telephones. They developed a guide to adolescent and youth health and development in the era of COVID-19. They reopened or reactivated public health facilities once the emergency phase of the pandemic ended in the country, and they extended integration of adolescent-friendly elements to new facilities. In order to determine if these modifications or additions are working, Pathfinder used quarterly reports from public health facilities with age disaggregated data. They sought feedback from their adolescents and from the peer educators, and they looked for the level of participation in the Telegram groups. The fourth promising initiative we'd like to share with you on contraception is from Marie Stopes, Uganda. Marie Stopes Uganda was already implementing a peer-to-peer paper referral intervention with behavioral science researchers before COVID-19 emerged. These interventions included a refer a friend card, and you can see a photo of that in the bottom left side of the screen. They also trained service providers on adolescent-friendly care, and they decorated waiting and counseling rooms with posters and refer a friend cards. When the COVID-19 crisis emerged, Marie Stopes Uganda did a few things to complement their existing services and modify them in response to the new restrictions. They distributed posters about service availability via village health teams and peer educators. They used an existing SMS platform called Marie Text to monitor their performance and share updates on MSI services. They provided remote supportive supervision to their mobilizers who worked in the communities, and they procured personal protective equipment for service providers to ensure that their own staff were safe and protecting the safety of visitors to the clinics. To determine if these modifications or additions are working, they're conducting a needs assessment to design the modifications in the first place, and they're conducting a randomized control trial to evaluate the impact of the Refer a Friend cards, even in the context of COVID-19. The last example on contraception that we'd like to share with you is from the Reproductive Family Health Association of Fiji. RFHAF was already providing contraceptive services to young people through mobile outreach and a network of peer educators before COVID-19. And then to respond to the COVID-19 crisis, the organization did a number of things. They established a helpline in partnership with the Ministry of Women. They provided telephone and online services. They adjusted their static clinic services by extending opening hours, implementing a new scheduling system, and ensuring infection control, including personal protective equipment. They mobilized retired nurse midwives, drivers, counselors, as well as youth volunteers to provide outreach services and support referrals of adolescents who needed services. And they shared information on social and mainstream media about the services that were available and how to access them. To determine if these modifications or additions are working, the organization is conducting exit interviews at their static and mobile outreach clinics. They are seeking feedback on social media and through private messages to the administrators of these groups. And they are holding monthly meetings with their youth volunteers via phone and via Zoom. The third intervention, including in this technical brief, is comprehensive abortion care. The general recommendation is to maintain and modify comprehensive abortion care services, and the specific measures for delivery of service include a number of items: to inform adolescents where and how to access comprehensive abortion care, including safe abortion to the full extent of the law, and post-abortion care through appropriate channels. In health facilities, to ensure that comprehensive abortion care remains available for adolescents, is safe, and is provided respectfully and confidentially. To consider relaxing policies to enable the use of telemedicine for the provision of medical abortion to adolescents to avoid unnecessary clinical visits. To consider reducing barriers that delay access to care and therefore increase risks to adolescents reverting to unsafe abortion practices. In particular, to consider waiving restrictions if these exist, such as on age, parental spousal consent, or marital status, and providing services subsidized or free of charge within the relevant legal framework and in line with international guidelines. To ensure that gender-based violence prevention and treatment services are available to the adolescent during the care encounter, or that the adolescent is referred based on their individual situation. To ensure that STI services are available to the adolescent during the care encounter, or that the adolescent is referred based on their individual situation. And then lastly, to counsel adolescents on and provide post-abortion contraception where desired to avoid rapid repeat pregnancy. The examples we'll share with you relate to the first recommendation, the second recommendation, and the fourth recommendation. The first promising initiative on comprehensive abortion care comes from the Sudan Family Planning Association. The Sudan Family Planning Association established a new call center to increase access to services in the context of the nationwide shutdown in April 2020. The call center is staffed by general practitioners as well as with obstetricians to provide abortion and contraceptive counseling and consultations. The providers also provide referrals for services in the organization's clinics or with community-based providers nearest to the caller's place of residence. And importantly, the organization is advocating to institutionalize this model of service delivery for continuation beyond the pandemic. The second promising initiative on comprehensive abortion care comes from Frhs India, which is the Marie Stopes International affiliate in the country. To respond to COVID-19, the organization used advertisements in newspaper and other media to communicate about the facilities where services are available and about ways of accessing these services. They used clinical outreach teams and ASHAs, which are a type of frontline worker in India, to inform girls and young women about available services and accompany them to the health facilities, navigating the mobility restrictions during the lockdown period. The organization revised its service delivery guidelines and protocols to ensure the safety of its clients and service providers from transmission of COVID-19. And then, importantly, in response to the economic effects of the pandemic, Frhs India also reduced the cost of its abortion services from 2,500 to 1,250 INR. To determine if these modifications or additions are working, the organization monitors its activities through field visits and online systems, including through review of videos sent by their field teams. The fourth intervention included in the technical brief is provision of antenatal, intrapartum, and postnatal care. The general recommended action is to maintain and modify services, and the specific measures include to inform adolescents where and how to access maternal care through mass media and digital media where adolescents have access to them, to consider using telemedicine for counseling and screening, including for risk factors known to be increased in the context of COVID-19 and to which adolescents in particular may be vulnerable, for example, mental health conditions and gender-based violence, as well as the occurrence of danger signs. Where comprehensive facility-based services are disrupted, the technical brief recommends to prioritize antenatal care contacts for pregnant adolescents, to ensure that birth preparedness and complication readiness plans are adapted at each contact to consider changes to services, and to prioritize postnatal care contacts during the first week after childbirth. They also recommend to put in place targeted outreach strategies where coverage and care seeking among pregnant adolescents have declined. It also points to additional advice in the UNFPA technical brief package on facility-based maternity service delivery and phone-based antenatal and postnatal care during the COVID-19 pandemic. The promising intervention here relates to both maternal care and mental health and comes from the University of Nairobi and the Nairobi City County in Kenya. Before the COVID-19 pandemic, an ongoing NIH Fogarty study was already using something called the WHO MH-GAP, which is the Mental Health Gap Action Program, a community toolkit to build awareness of the mental health needs of pregnant adolescents. It used the WHO MH-GAP IG, or the intervention guide, to integrate screening of common mental health problems in primary care centers, and it offers group interpersonal psychotherapy for moderate to severely depressed pregnant adolescents. To modify these services in the context of the COVID-19 pandemic, the study trained additional health workers using Zoom on the MH-GAP and on interpersonal psychotherapy. It built the capacity of community health workers around mental health via phone messages, seminars, and CMEs. It worked with youth-led organizations and youth leaders to disseminate messages about self-care and mental health. It established a hotline and an online psychotherapy service, and it set up Zoom and Skype groups to provide self-care and psychological first aid and to support referrals even in the context of mobility restrictions. The fifth intervention included in the technical brief relates to prevention and treatment of HIV and other STIs. Now, there are a number of recommendations included in this section, and I'm not going to read them all. I welcome you to refer to this section of the technical brief if you're interested in seeing them all in detail, but I want to highlight a few that we'll be discussing in relation to the promising initiative. The first is that where possible, use digital platforms and mobile health strategies to minimize clinic visits to provide adolescents with test results, treatment and prevention messaging while ensuring privacy and confidentiality. The second is to modify services to promote out-of-clinic delivery of elements of the advanced disease package of care, prophylaxis screening for CD4 count and tuberculosis screening, and to inform adolescents where and how to access HIV and STI testing and care where access is possible through mass media and digital media. The promising initiative we'd like to share with you on HIV is from a program called Zvandiri, implemented by Africaid and a number of other partners in Zimbabwe. Zvandiri was already providing individualized case management for young people living with HIV, and this included individual and joint home visits, clinic-based support groups, and a mobile app called Zvamoda. To respond to the COVID-19 crisis, Zvandiri modified these service delivery pillars. They had youth-led development of evidence-based, age and developmentally appropriate information on COVID-19. They instituted virtual case management to provide information, counseling, to identify red flags, and to provide referral services. They had targeted home visits by mentors to provide ART refills and viral load monitoring, to do tracking and tracing, and to screen for other health risks. They had virtual support groups to do similarly information sharing, group counseling, and sharing of experiences and coping strategies, as well as referral. And they expanded and scaled up the Zvamoda app that provided information, that facilitated ART refills, that supported adherence and viral load reminders, that actually facilitated counseling as well, and that supported referrals. To determine if these modifications or additions are working, they conducted a rapid needs assessment in April 2020 to design the modifications that would be made. Zvamoda, the app mentioned above, allows for real-time data collection for case management, monitoring, and tracking. They conduct joint planning and review with the health facilities, and they have virtual beneficiary and stakeholder engagement on an ongoing basis. The sixth intervention included in the technical brief is prevention, care, and response to sexual and gender-based violence. This includes sexual abuse and sexual violence, as well as child marriage and female genital mutilation. The examples here that we want to share with you relate to a few of the recommendations, specifically to establish helplines or enhance existing helplines for adolescents to seek help if needed, to inform adolescents where and how to get care, where access is possible through mass media and digital media, and to sensitize and alert healthcare providers, community workers, and support networks to the potential for increases in sexual and gender-based violence and ensure that they are aware of adolescents' specific vulnerabilities. For example, their limited ability to report abuse. For the remainder of the recommendations in this section, especially those on child marriage and FGM, I suggest that you look to the technical brief. The promising initiative on gender-based violence comes from an organization called Center for Catalyzing Change in India. C3 conducted a telephone survey with adolescents and young people early in the pandemic, and they found through the information that they gathered that domestic violence was a cause for concern among adolescents. They also found, though, that few adolescents knew where support was available and how to access it. In response to this, C3 advocated with the government of Jharkhand, which is a state in India, to raise awareness with communities, to build the capacity of frontline workers on counseling and legal procedures to support services related to gender-based violence among adolescents, and to ensure the availability of a mobile phone in each village that girls could use to access helplines and other supportive services. C3 also involved counselors based in adolescent-friendly health centers in the telephone counseling services, and C3 is also directly reaching out to adolescent girls and young women to provide information and support through digital platforms like YouTube, WhatsApp, and community radio. The seventh intervention included in the technical brief is prevention of cervical cancer through HPV vaccination. Here, the recommended action in general terms is to modify the provision of this service. The specific recommendations are many, as you can see on the slide, and just like for the previous intervention, I'm just going to highlight a few and encourage you to look at the technical brief for further information. The ones that relate to the example that I'll share with you include that if school-based HPV vaccination initiatives continue, or when they resume, infection prevention and control measures need to be implemented to avoid increased risk of transmission of the COVID-19 virus among students, school personnel, and healthcare providers. And to inform health workers and others involved in different aspects of HPV vaccine delivery about altered HPV schedules and updated age restrictions, and to communicate the importance of HPV vaccination and the efficacy and safety of the new schedule or longer interval between vaccine doses. And finally, to inform adolescents and their parents about the importance of a full series of HPV vaccination and any altered HPV schedule, reassuring them about the efficacy and safety of HPV vaccination and the alternative intervals. The promising initiative on HPV vaccination comes from the Ministry of Health in the Lao People's Democratic Republic. The Lao MCHC and National Immunization Program decided to introduce the HPV vaccine in 2017 with a planned rollout in March 2020. In preparation for this, they trained health workers via videos and interactive PowerPoint slides. They communicated and mobilized communities with social media and with branding. And they planned for a school-based program with complementary health facility-based and outreach programs for those not in school. However, in March 2020, of course, COVID-19 pandemic was causing disruptions around the world. And to respond to the COVID-19 crisis, the Ministry of Health worked with village heads to identify vaccination service delivery sites in the community. And they issued new communication messages to provide an update on plans for the programs and where and when the vaccination services would be available. Because of these modifications, they actually were able to continue with the rollout of the vaccination program despite COVID-19 in most parts of the country. To determine if these modifications or additions are working, the Ministry of Health intensified provincial supportive supervision meetings, and they involved the polio stop teams who had experience with vaccination programs. And they used careful management of adverse events to protect vaccine confidence. The eighth and final intervention included in this technical brief is counseling and services for sexual health and well-being, including provision of menstrual health information and services. The recommendation in general terms for this intervention is to maintain and enhance the services, and specific measures for delivery of services including advocate with authorities to ensure that affordable menstrual products are available in stores as an essential service, to advocate for the inclusion of menstrual products in the distribution of food or non-food items to girls with limited movement or those in camps and institutions, to use contacts with a healthcare provider to dispense menstrual products and information to girls about alternative reusable menstrual products in particular, to engage community groups to extend the availability of affordable menstrual products, to ensure that menstrual health information is included in health service provision and that it is provided other health information efforts, including those on health self-care, and to ensure adequate access to essential medication for people under long-term treatment, for example, hormonal therapy as part of gender-affirming care. The technical brief also points to further recommendations on menstrual health during COVID-19 in a UNICEF brief titled Mitigating the Impacts of COVID-19 on Menstrual Health and Hygiene. The example that we'll share with you relates to a few of these recommendations, specifically to engage community groups to extend the availability of affordable menstrual products, to advocate for the inclusion of menstrual products in the distribution of food and non-food items. The case example on menstrual health comes from an organization called Footprints Foundation, as well as the South African Coalition for Menstrual Health and Hygiene Management in South Africa. Footprints Foundation was already implementing programs related to menstrual health before COVID-19 pandemic emerged. These included puberty education, provision of menstrual products, and wash improvement in rural communities across the country. When the COVID-19 pandemic emerged, the organization partnered with a number of government departments, including the Department of Women, Youth and People with Disabilities, Basic Education, Gauteng Social Development, and with the SRH Institute. By doing so, it secured special permits for movement and delivered dignity packs and food parcels to schools, shelters, youth health centers, and facilities for persons with disabilities. They then contacted beneficiaries of the program to come to the locations to collect their supplies with respect for the mobility restrictions in place. To monitor whether these modifications or additions are working, they have a formal monitoring framework that supports their ongoing monitoring activities. And they use a platform created by the coalition to share information about the activities with a number of partners to ensure alignment and complementarity. That brings us to the end of the technical brief and the collection of promising initiatives that we've shared with you today in this video. We're doing a lot of activities to disseminate the learning of this technical brief. We've translated it into French and Spanish and are disseminating it to countries to support actions related to adolescent sexual and reproductive health and rights. We're conducting this e-course, of course, with the Geneva Foundation for Medical Education and Research to spread the information included in the technical brief. And we're using an opportunity of an adolescent and youth sexual and reproductive health and rights technical assistance mechanism to provide country support upon request. We're also really interested in learning from country work. Including the examples that we shared with you today, we're building a bank of case studies on an ongoing basis with partners within and outside the UN system from all 6 of WHO's regions. If you have examples that you'd like to share with us that you think match some of the recommendations included in the technical brief, we'd be very happy to hear from you. Our intention is to make this bank of case studies available to those who are interested and to synthesize the learnings, for example, on how the experiences have been applied, what it takes to apply them, and what the responses to them were. That brings me to the end of this presentation. I'm going to hand over to my colleague Chandra to share a few concluding messages on responding to the sexual and reproductive health needs of adolescents in the context of COVID-19. Thank you.
Thanks, Marina, for passing on the baton to me. I'd like to conclude this presentation with 5 points. 1. Adolescents are sexual beings, COVID-19 or not. Over the past 9 to 10 months, all our lives are on pause in some way or the other because of COVID-19. The quotes from adolescents that you see on this slide suggest that too. For example, when will this pandemic end so that I can go back to school and meet my friends? Despite being on pause, adolescents everywhere are continuing to grow and develop physically, psychologically, and socially. Just as for adults, their sexual thoughts, feelings, wants, and needs do not go away just because of lockdowns and disruptions. The second point is that menstrual periods do not pause for pandemics. This is a quote from the menstrual hygiene movement, but neither do love and sex. And adolescents are a diverse group in different stages of development and in different life circumstances. For example, some of them are married, others are not. Some adolescents are not yet sexually active, others have sex consensually, still others are coerced into having sex. And of course, both consensual and coerced sex occur within and outside stable relationships. All these groups of adolescents have needs for information and services, differing needs and changing needs that need to be responded to. My third point is that from 40 years of experience in HIV prevention and in other fields, we know that simply saying no or don't do that does not work. We must protect adolescents, of course, especially those who are most vulnerable and young from risks, for example, from cyber predators or predators in our homes and communities. But as they grow and develop, we must progressively empower them to make and act on their own decisions. We must prepare and support them in making these decisions, and this includes helping them understand that the presence of their peers or being upset or excited can affect their ability to make decisions and, even as importantly, to act on them. My fourth point is that we need to move from ignoring adolescents altogether, or even worse, blaming them, to meaningfully involving them in finding solutions that affect their lives as well as the lives of their families and communities. In response to a question from a journalist in one of WHO's bi-weekly press conferences on COVID-19, Dr. Michael Ryan, Executive Director of WHO's Health Emergencies Program, said what you see on this slide, and I'd like to read it out aloud. He said, "We need to have a conversation, and young people need to lead that conversation. The last thing a young person needs is an older person pontificating and wagging their finger." And he said that it never worked with him. We need to find better ways to engage young people. We need to give young people a responsibility and a voice in this, empower them, and resource them to do it. He couldn't have said this better than any of us working full-time in the adolescent health field. My last point is that the COVID-19 crisis is clearly both a huge threat to individuals, families, communities, and wider societies, but it's also an opportunity for all of us to build back better. I'd like to conclude with 4 points. 1, adolescents continue to face barriers in obtaining and using the SRH services they need. These barriers are not new. They didn't come because of COVID-19, but they've always been there. However, for many years, NGOs have used innovative ways of overcoming these barriers. In recent years, a growing number of governments are taking the lead. The government of Chile, the government of Uruguay, the government of Ethiopia, the government of England, and there are a growing number of governments taking the lead and achieving nationwide results. The third point is that the COVID-19 crisis provides a powerful lever to challenge and change all these barriers. Barriers such as restrictive laws and policies, barriers such as parental and partner control to access to services, barriers such as health worker bias. COVID-19 provides a powerful lever to upturn and throw these barriers away. But moving forward, data and evidence are not just assumptions, must drive the design and execution of these efforts. Innovative approaches are not necessarily effective approaches. Innovative approaches can show the way, but they have to be proven through research and evaluation to be classified as effective and then scaled up. And in everything that we do, adolescents need to be fully involved, meaningfully involved. Thank you and goodbye.